All right. Good morning, everyone. Welcome to Third Thursday. I'm excited for this Third Thursday. I'm excited for the topic. But just a couple of announcements. I apologize for the paperwork. I had it all set out late last night, ready to go. The cleaning people came in and did too good of a job and took my paperwork. So in regards to your sign-in slips and stuff like that you are used to, I'm going to go reprint it off this morning at the beginning of Tim's presentation here, and then I'll have you sign out. How about that? So I appreciate you being here. This is our 10th Third Thursday, and we are in our second phase of our initiative for launching this Third Thursday. In the second phase, just to remind you, our goals were to try to get CEU sorted out. We're working with MCA on that, and MCA has also been sponsoring our breakfast, so that's been great. And then also the other objective for this second phase was to get it online somehow so that our alumni and so on that are remote from the Minneapolis area can log on and either see it live at some point in time, that might be a phase 3 thing, or at least see a library and archive of them. So we're getting close to getting that taken care of for you. So phase 3, I'd like to potentially launch this as a live opportunity, and James might be able to help us with that, as well as be able to maybe even have vendors here in the morning, where we have vendors in the back or out in the hallway, and just again contributing and showing you some cool toys in regards to sports care. So without further ado, again, I'm excited for this topic. Basically the role of a paramedic on a sports medicine team. I think that probably sums it up. Tim puts in fancier words. I think it's great. And Tim is a friend of many of you here, right? He teaches our EMT program here on campus. He's currently teaching a class now, and hope to continue offering this EMT class on campus because I think it's a great thing to have if you're going to be moving down the path of being a sports care provider in some manner, right? So I would like to turn it over to Tim at this point, and he can finish introducing himself. Thanks, Tim.
Sounds good. So, like I said, my name is Tim. I'm a full-time faculty member at Denver Hills Community College. So I do everything from our emergency medical responders up through post-graduation education for paramedics, immediate paramedics, critical care education for furthering out their experience and education. So I don't want to spend a lot of time here talking about myself because we have a lot of things to cover, and I'm told that 8 o'clock another class comes in, so we better cruise and get on through. So one of the things about EMS is that we are really one of the best kept secrets inside healthcare. We talk to other healthcare providers and you ask them, well, who are these EMS people, how do they work, and all that. Even if you talk to an ER nurse, I mean, the people that we encounter the most, oftentimes they say, I don't know, they drive the big trucks and they have lights on them. And that's about the best description they can give of what an emergency care provider does. So I just wanted to get a little bit into what EMS is, who the people are that are working out on these trucks, kind of what our view of the world is, what our priorities are when you arrive on scene, so that there can be a little bit of a better understanding as to how we go about operating. So this is a quote that I like in particular. Now this, I also teach a class that's on, we call it Emergency Response to Crisis, and oftentimes people think that this is going to be your mass casualty class. It's actually not. It's one that we talk about the behavioral health, particularly of healthcare providers. So part of the job is having long hours, rather undesirable hours. I don't know about you guys, I don't like being awake at 2 in the morning. I'm not sure if anyone likes being awake at 2 in the morning. But we're oftentimes awake at 2 in the morning, and even on Christmas Day. It's 24/7, 365 profession. So we don't get holidays off, we don't get any of that stuff off. And we end up going from oftentimes moments of absolute boredom, and then 5 minutes later you're in a moment of absolute terror, just based on whatever is going on at the time. So oftentimes people ask, well, why do you do it? You know, is it just for the adrenaline rush because you want to be doing something that's absolutely crazy? And oftentimes the answer isn't so much yes to that. It's like, do I have a little bit of an adrenaline need? Yeah, honestly, most people in EMS do have a little bit of need for adrenaline. But so when you get right down to it, the reason that most people are in this kind of profession is that they've seen something in their life. Take, for example, a good friend of mine, Brent Custer. He ended up getting into EMS because he had a flare-up from a fuel tank inside of his garage and ended up being in a burn unit for 6 months. getting different skin grafts, things taken care of, and what really stood out to him through that entire experience was the ambulance crew that responded to his house to take care of him. So all through that, he had 6 months of lying in the barn unit to sit there and process about it, and decided, you know, that's what I want to do. Is that I've had this experience, I know what it's like to be on this end of things. Now it's time to go kind of pay it forward and give somebody else that kind of experience. So I think this quote kind of gets down to a little bit of what motivates us as a profession. So when we get down to what an EMS provider is that really we're the hands, eyes, and ears of a physician in the field. So if you go back, say, 100 years, you might have had some doctors put together the little black bags and go out and actually see patients in their homes. How often do you see physicians in people's homes nowadays? Probably not much, huh? I'm not saying they're not out there at all. There's a few that actually do still go out there, but it's not very common. So especially as we look at more recent developments, their time's becoming a lot more precious, and there's a lot of drive to have your 15-minute clinic appointments, just keep people moving through as quick as possible. A little bit of a financial drive. The more patients you see in one day, then the more money you make as a clinic, and there's a little bit of a culture that's really promoting that. So the ability to be able to have people that are going out in the fields to see patients, it's not really happening so much. And if you go back, not even 100 years, just go back 50 years to the 1960s. So in the 1960s, if you had to go to the hospital, you're at home, you're very sick, you can't move yourself, you need to go to the hospital, who'd you call?
A cab.
Heck, you might call the cab, who of course shows up, and you have to kind of haul your way out there, make it out to the side of the street and get on, and if you took too long, the cab would drive off again. Or let's say that you had to make a horizontal drive into the hospital. You weren't able to sit up. What you would go is you go to the Yellow Pages and look up your local funeral home. They're the ones that had a vehicle that was designed to give people horizontal rides. And so the same person that's delivering around caskets is also the same one that's around delivering patients to hospitals. That's what it looked like at the time. So oftentimes I talk about EMS being in its infancy and moving to its toddlerhood now as it's starting to develop more as a system. But there was a need notified that kind of put out there saying that we need to have somebody that can take care of patients in the field and provide medical care quicker. We shouldn't be having people not getting medical care at the moment that they make contact with someone and then continuing that care on the trip to the hospital. And that's kind of where EMS comes from. So the way the system was developed is that every medic, every EMT, everybody in EMS, whatever your position is, has a physician supervisor. So another position that you might be just a little bit more familiar with, it has a very similar look to it, is a physician assistant. So say that a physician assistant wants to go out and make their own clinic and not have any physicians that they work with. Can they do that? No, you always have to have that supervising physician, and it's very much the same look for EMS. So we refer to them as a medical director. So every medic, every EMT knows who their medical director is. They have contact with that medical director, and you work underneath their license. So when you have an EMS crew on scene, they do work under a physician's license. They have to have contact or the ability to contact that physician. And they also have permission to practice based on the license parameters of that physician's license and their education. So providers come at 4 different levels in the National Scope of Practice model. I will say though that we do have 50 states, and of course who determines what you can do in each state? So each individual state. So do we have 50 different EMS systems in America? Yes, we do. So there are some variations as you go around to different states. And I will say that Minnesota, and I'm not just saying this because I'm from Minnesota and live in Minnesota and work in Minnesota. It's not completely on that. I spent some time working as a flight medic doing fixed wing transport and got around to all sorts of different states and had a chance to talk to a lot of different people in the profession. And I will say that Minnesota is very well equipped and has very, very aggressive leanings for its EMS system. We tend to be on the forward edge and a lot more progressive than some other states. So when you take a look at this National Scope of Practice, there's 4 different levels. There's emergency medical responders. So when we take a look at these people, these are the ones we anticipate will be on scene first. We want to have a lot of them in the community. We want them to be very prolific. We want the time from the 911 call to the arrival of an EMR to be the absolute minimum time that we can get. So usually people at this level are going to be police, firefighters, people that are going to be throughout that community and a relatively short distance from any call that takes place. One thing about EMRs though is that they do not work on the ambulance. You cannot be in the back of the ambulance taking care of a patient during transport. That's not what that level is meant for. So it's the first response level, they're going to get on scene right away. So the entry level for somebody that's going to work in an ambulance, if you want to be on it, you want to be taking care of patients during transport, you want to go to the next level, emergency medical technician or EMT. So that's the class that we teach here on campus, and it's relatively involved. The best way to put it is kind of the jack of all trades and the master of none. So as you go through class, you're going to basically take medicine. What kind of medicine? Basically, yes. So you're going to have your medical patients, you're going to have your trauma patients. Do we do OB, GYN? Absolutely, we do all of it. How deep do we go into all of it? Well, let's say that you want to be an obstetrician. How much school do you need to go really deep into obstetrics? 8 years now, I think. 11 if you put the residency on the end. So we're not going to go to the point that you can take care of all things obstetrics, but you're going to be able to handle what we call just stabilizing care. The goal is to be able to get the patient stable and then move them to a location at which they can receive further care. So that's what we're looking at with our EMTs. Then we have an advanced level of EMT, has a few more skills. So I'm a little bit heavier on the medication side of things, and we also add in IVs at this point. And then we have paramedics. And paramedics, this is probably the most misunderstood level of EMS provider. So did anyone ever watch an old TV show called Emergency? So I was going to say, there's a few nods out there. If you haven't seen it yet, it's on Netflix. You should check it out sometime. So this came from the 1970s, Johnny and Roy, Station 51, and this was, I would say that of all things out there on TV, you know, most shows and movies about EMS are, you know, I don't watch them. I can't watch them because I'll make my wife too mad by looking in there. You only have TV about how wrong everything is. So, but this one was actually relatively accurate. So back in the 70s when medics were just coming to be, there's a lot of people going like, oh, they're just a bunch of cowboys out there doing whatever the heck they want to do, and they have no idea what the heck they're doing anyways. So, and the system at the time was, it was a very technical approach. So every time they arrive on scene, they do an assessment and they get on the radio phone. So it came in a big toolbox about yay big. That's actually pretty accurate as to how big the old ones were. And they call back to Ranford, report down the assessment findings that they had, and they receive orders from the doc as to what they're supposed to do. And that was the system at the time. We've really grown away from that kind of a system. So when we take a look at the current days, in any given year, anyone care to guess how often I'll actually speak to a doctor from a scene?
Twice.
Yeah, maybe 2 times. So far this year, I can tell you, we're up into the 10th month now. I've done it once. I actually started kind of keeping count at the beginning of this year. I've been kind of going off my own personal impression, but I figured that I'd better actually keep count. I called once. It was on Tuesday. So we really don't run on that kind of a system. A paramedic is a very independent practitioner. They also have a good education. It goes much deeper into pathophysiology, disease management, and a very strong emphasis on being able to put together a patient care plan based on your assessment findings. That's probably one of the biggest pushes that we have right now, is to make sure that you really gear your care plans towards that individual patient. What does the patient need? What are your assessment findings telling you? Make sure that you head off the disease process before it gets bad. So the old ounce of prevention is worth a pound of cure. So understand where they're going. What can I do to stop this disease progression and keep that cog from running forwards on that disease? So generally speaking, we got these 4 provider levels, and we run 2 different levels of ambulance services. We have the basic life support ambulance. This is staffed primarily by emergency medical technicians. Now, depending on where you go in the state, you may have BLS ambulances as your primary EMS source. So say that we go off to, let's pick on, let's see, Albert Lee actually just moved up to ALS, so I can't pick on them anymore. But let's throw this one out there. Is anyone from a small town? What town are you from?
Iowa.
Oh yeah? They run off BLS ambulance. What other small towns we have people coming from?
Holly, Minnesota.
They're also a BLS ambulance, but they do have an ALS contract with the neighboring one. Anyone know what Graceville, Minnesota is, perchance? That's the problem with picking small towns. It's really hard to pick a small town that you can be pretty confident everyone knows. Who knows the zit on the back of Minnesota? Let's put it that way. Little Bump kind of goes out towards the Dakotas. Graceville is in the middle of Big Stone County. Big Stone County is the bottom half of that bump. So that's where I actually got my first ambulance job. Was working as an EMT for Graceville Ambulance. We had 200 calls a year. That was our run volume, and ran BLS. Employed only EMTs. So that might be the level of service that you have, period. That's all that's available. So what you'd expect from these services then is that we're going to run things at a basic level, and the goal is to get transport in motion. So get your patient stabilized, do what you absolutely need to do right now on scene so that the patient doesn't expire by the time that you get them in the truck, and then get in the truck and get moving towards a hospital. So another level then, that's going to be a lot more common around the metro areas, is advanced life support. Now the cost difference going from basic to advanced life support is really significant. So the credit load for becoming an EMT is 9 credits. The credit load for becoming a paramedic is 75 credits. And that's beyond EMT, so you must have had EMT prior to that, so it's really a total of 84 credits. So the education difference, the amount of time that you have to invest in that is pretty significant. So you might imagine that you then have to pay them more to have that education background, on top of the equipment being a great deal more expensive. So an AED will cost you around $2,000. A cardiac monitor that we carry on one of these trucks is about $35,000. And that's on top of the fact that the truck already costs $200,000 to begin with. So the expense really goes up, and when you have a smaller population, you just can't make that kind of expense. So that's why you only see advanced life support around more urban areas that can actually kind of handle that kind of a cost. But as you move into an advanced life support service, you start adding in services that you wouldn't have otherwise. So when we take a look at basic life support, what kind of things would you expect to learn in the EMT class? What kind of things do we work on? So we get some basic assessment up and running. That's always where I like to begin. If you can't assess, you can't make a decision to do anything much past that. So that's what I put down as being the number one essential skill. But beyond that, we're going to work on basic airways, being able to keep people's airways open, vomit out, splinting of different extremities, different types of injuries, so that you can get those stabilized. Spine mobilization, I will make one small comment on this one. Now, this is another area that's changing quite a bit. When I started in this 15 years ago, if you had somebody with a stubbed toe, you'd immobilize their spine. We used to use spine guards prolifically and, frankly, way too much. We've stepped back on that one a little bit, so as we kind of go a little bit into the presentation, that's a little thing that'll kind of work into our case studies as we get there. And then bleeding control. So, has anyone ever heard that tourniquets are bad and you shouldn't use them? Oftentimes people go, it's like, this is a method of last resort, you should really avoid using it, and if you end up having to use it, that's because you failed in every other aspect of your job. That's how they used to be explained. We actually like them, they're good, you should use them. We'll also talk about that a little bit as we go through our case studies. And then CPR certified, so everyone when you come into EMT class should be a BLS provider. So I know that John Williams teaches those classes here on campus. So we require that. We go a little bit deeper into that and talk a little bit more about post-resuscitation care. And then your primary tool for working with that is going to be an AED, an automated defibrillator. So then when you move over towards advanced life support, once we have medics responding to these calls, we're going to start running into advanced assessment. Like I said, if I had to name the number one difference moving from paramedic, it's going to be EMT to paramedic, is that you really dig deeper into that pathophys. We really have to expand out that knowledge base. So when we talk about the skills performed by a paramedic, well, I could probably go down to a Como Zoo and grab a couple of animals that they have in there and teach them how to do the skills. What I wouldn't be able to teach them, they don't quite have the thought capacity for it, is to decide when to do those skills and when not to do those skills. That's where the real decision comes on in, and that's where the real difficult part of the job comes on in. Now, anyone can learn the skills, but you really have to work on that the knowledge background to be able to decide when it's appropriate, or even more importantly, when it's inappropriate to start moving on to the advanced stuff. So we have advanced airways, so intubation comes in at this point, placement of tubes down inside the trachea. Also, along the same note, surgical airways, things like that all come in at the paramedic level. The medication list gets expanded out by a great amount. A typical ambulance will carry about 50 medications on it. An advanced life support ambulance will carry about 50. And then other invasive procedures such as chest decompression, getting air outside of people's thoracic cavities, that's all something that comes in at the paramedic level. And then advanced cardiac life support. So there's a little bit of a response difference of basic life support ambulance compared to advanced life support ambulances, particularly cardiac arrest. So when you look at the chain of survival, getting early ALS is one of those links in the chain of survival when you take a look at CPR. Well, when you take a look at what a emergency room is going to do for somebody in cardiac arrest, that is the exact same thing that you will get from an ALS ambulance. So while a basic life support ambulance might try to initiate transport early in a cardiac arrest, an advanced life support ambulance is going to remain on scene and work that cardiac arrest until it's decided one way or the other. So as a general rule, an ALS ambulance will not transport somebody that does not have a pulse. If they do not have a pulse, we're going to sit tight wherever we're at and continue to work that arrest. So that's how we end up getting some better outcomes. If you're in motion trying to do CPR, is anyone, who has done CPR training, by the way? Now imagine doing that on a patient that's actually up at about your thigh level, so this is all the more leverage you get on it. And now put it 90 miles per hour down I-94. What's your CPR going to look like? It's hard enough when they're on the ground and you can actually get leverage and kneel over them. That's an exercise for 2 minutes. Once when you're bouncing down the road, your compressions are terrible, and if your compressions are terrible, what's survivability in cardiac arrest? Really not good. So that's part of the reason that we're trying to really bring that stuff out to the patient bedside and keep that going. So that's another one of the large differences that you'll see as you move on.
See, Tim, could you check your mic?
Oh, yep.
You might lean against it. Not for us so much, but more for the video.
Check. A little bit better. Okay. I'll just, there you go. One thing that we do need to cover, just because it is a consideration, is legal issues. So, which by the way, can you still hear me in back? Okay, I'll try to up the volume just a little bit. We do have an obligation, of course, to meet our legal requirements. So it's not a bad idea to talk about what those legal requirements look like for EMS. It's going to be things that we think about. It's going to be things that end up affecting maybe some of the decisions we make. So in terms of authority on scene, so let's say that we have a multi-dimensional team on scene. We have nurses, we have sports chiropractors, sports trainers, some occupational therapists. Let's just put as many different people on that scene as we possibly can. Now, at this point, 911's been called, and the ambulance unit is now on scene. Who's running the show? One thing I'm very fond of saying, and anyone that's ever taken class with me has heard me say this before, is that this is not going to be run by committee. Is that it's when you have an emergency scene, it's more of a dictatorship. So there has to be one person up top that has the plan, running the plan, and keeps the team on track. You can't just sit there and have a committee decision. Nothing will ever get done, and things do need to move along. So a simple question is, who's in charge? Confusing point, right? Believe it or not, there's actually legislation that does actually dictate this one out. If you have an emergency scene, if 911 has been initialized, then the ranking medic on scene is going to be the one that's in charge. So if there's any kind of conflict between different providers on a scene in which 911 has been initiated, you go to the ranking medic. At that point, you do have to follow that direction. Now, might they be wrong? This is always kind of a touchy one. Does that mean that nobody else on the team should be contributing or maybe pointing out saying, hey, did you think about maybe the fact that they're bleeding out on the ground and you're not doing anything about it? You know, it's still a team effort. That's one big thing that always needs to be understood, is that it's still a team effort. So even if it's my partner's call, say that I'm the one that's going to be kind of off to the side and my medic partner is one that's actually going to be in charge this time around. If I see that they're missing something, Is it my duty to speak up? Add that on in. Absolutely. So the entire team does need to function. Everyone's responsible for certain things all the time. Say, for example, safety. If you see something that's about to get somebody injured, you have to speak up. You can't just sit back and say, well, technically it's their problem. No, technically it's everyone's problem. We all need to focus on that. So in terms of state legislation, it is going to be the ranking medic on scene that is supposed to be in charge. Now let's say that we have another physician on scene. Who's seen this one where you end up with two doctors arguing? Or anyone ever do like rounds with MDs, or ever seen like residency? Once when you get all the first, second, third year residents all together for their case studies. Have you ever seen what happens at those? Boy, if you've ever think that you've seen some arguments before, you got nothing on these guys. The first time I went to one of these, they ended up having a case go up, and there's literally people standing up, yelling at each other, throwing things across the room. It was probably one of the most spectacular arguments I've seen in my entire life. People tend to get very opinionated. It does happen. Now, do you want that to happen in front of the patient? So, of course, it needs to be a certain other way that we handle it. Oftentimes by going, well, have you thought about maybe putting something on that meeting item over there? Have you thought about doing this? So you want to make sure that you keep that moving as a team. And then we come down to issues of consent. This is oftentimes where we end up with people that are very frustrated. So probably the context that I see it in the most is at nursing homes. So the nursing home sees a patient, they're looking really sick, they want them to go to the hospital, but the patient doesn't want to go. So if I'm standing in the room with a nurse, the RN for the nursing home, and the patient, the nurse is saying, they have to go, we can't keep them, and the patient saying, there's no way you're going to take me to the hospital today. Absolutely not. I'm now stuck between two different places. This is now an issue of consent. Does anyone know what my legal requirement would be on this?
Refusal for transport consent?
So, can I transport the patient? No. I cannot transport the patient because the patient is the one that makes the choice. As long as they're alert oriented, they can tell me who they are, when it is. If they end up being completely altered, if they think that it's 1962 and not the taxi cab that's kind of going to bring them to work, that's a different story. They cannot understand what's going on at this particular moment, and we'll have to defer to what we call implied consent, or acting as if the patient did give consent, is what we're moving under at that point. But if the patient is alert oriented, which if we put this in the sports context, say that we have somebody that absolutely got their bell rung out on the field, and they were out for a bit, the ambulance shows up, now they're starting to come to, and they're saying that, they can't stay here, we have to have them sent down to the hospital, and the player is going, no way, you're not taking me down to the hospital. What do we end up having to do? We have to respect the patient's wishes, which can be very frustrating at times. I end up being frustrated with this periodically too, but we do end up having that requirement. So when we end up treating patients, we do need to do it with the patient's consent. Otherwise, it's assault, battery, kidnapping, all that type of stuff comes into play. It can actually end up being criminally liable for taking somebody against their will. So we do end up having that limitation too. Sometimes you have a whole group of healthcare providers in, they're looking at a patient going, you need this. You need this. If you don't get this, it's going to be very bad for you. And the patient just simply says, ain't no way. Are people allowed to make bad decisions? Absolutely. One of the great things about America, you can make bad decisions if you want. Everyone has that right. So we do have those issues of consent that we do need to kind of play around with. And then to kind of get into the frame of mind of an EMS provider when we arrive on scene. So we're coming in, usually your information is very bad. The most common thing that I get from dispatch, and this is the extent of the information I get from dispatch prior to arriving on scene, is sick person. So 735, code 3 to Northwestern Health Sciences University for a sick person. To which I'm going, well, of course they're sick. I hope they're sick because we're being sent there to go take care of somebody. If an ambulance shows up, somebody probably should be sick. And if nobody's sick, you start thinking behavioral reasons. Now, if you call an ambulance for no reason, you should probably talk about your mental state. So That's about what we know coming in. So the way that we always frame it up when we come onto a scene, our mindset, what we're thinking about, we walk into a room, and I call this the 5 seconds of calm before the storm. You walk in, you should survey everything, take a look around, and what I really want to know is air going in and out, and is blood going around and around. So I might be coming onto a field where somebody's knee is pointing 90 degrees off to the left. Not typically supposed to go that direction. They might be on the ground screaming, absolute pain, people around them trying to take care of them. People want me to go take care of that knee right away. But I'm still gonna come in, and my first thought is, okay, they're screaming. What needs to happen for you to scream? You gotta have air movement. You're not gonna scream without air movement. To me, that's a good thing. If I come into a scene and I hear someone yelling, I'm going, oh good, this is awesome. I know that air is moving, and of course, does blood have to be going around and around for you to be mentally with it to scream? At least adequately. So, if you had no blood moving, you probably won't be screaming right now. So to me, that's actually a happy thing when you come in and see that. We have had periodic complaints. I always thought that this one's kind of a fun complaint that we get, showing that the crew did not demonstrate enough anxiety regarding the patient's condition. That is actually a complaint that we get periodically. We just didn't look anxious enough. We appeared too calm. And that's part of the reason for that is that when you have something that looks to be completely off the rails, completely out of control, it's usually because somebody's making a lot of noise, moving around a lot, there's a lot of activity going on. Once again, to us, that's a good thing. We like seeing that. Lots of activity means your vitals are probably pretty darn good, and that's going to be our initial focus as we come on the scene. Everything else that comes after that is secondary. So this comes back down to our education again. So when you come on, we check out airway, breathing, circulation. If anything is compromised with those three things, all other secondary concerns, so that joint injury that you're seeing, the one that looks really flashy, or somebody that's got a ton of road rash on them, a piece of their nose is kind of pulled off to the side, anything like that, is that stuff going to compromise circulation? No. So that stuff we're going to leave sit until we're in transport to the hospital, and we will not delay that to take care of these secondary issues. So for a lot of other people, let's say that you were somebody that typically works the sidelines of a sports game, you're used to taking care of knees, ankles, and you could probably beat the pants off me in terms of getting some of these things splinted. Is this going to look like it's the wrong thing to do? It's just a different mindset, right? So different priorities, different views. So it's a different mindset. So sometimes it's just helpful to remember this is what's kind of going through our mind when we come in. So when you talk about times at which you really want to have this kind of a mindset, when is it that the EMT and the paramedic is really going to shine in terms of their management of the patient? Major bleeding. So we've had a couple of cases. In fact, my wife is also a medic. She actually took care of exactly this kind of an injury in a high school hockey player. It's actually rather substantial how many times this one actually happens. A hockey skate to the neck. So there's a couple of times this has happened in the professional lines. That's what this one's actually pictured from. And came up and they have a constant flow of blood coming out of their jugular vein. Life-threatening? Absolutely. This is exactly the kind of stuff that we're looking for, and exactly the kind of thing that's going to get us moving and moving quick. So quick stabilization, we'll move on off. And then injuries which cause a loss of consciousness. So right now, kind of one of the hot topics is the concussion protocol, right? So accumulated damage over a length of time due to multiple concussions. So we're just kind of getting some better research out there showing exactly how damaging that can be. I expect that's going to be something that kind of develops over time. You're starting to see concussion protocols being implemented in some of these sporting events. But here's what a medic's going to think with this one. We tend to be very pessimistic. So if somebody was knocked out on the field and now they're starting to come to, it sounds like a concussion, right? Does anyone know what we're going to end up thinking this might be? Because it's another thing that my students end up getting kind of sick of, the you should suspect questions, right? Everyone has that terrible nightmares off the you should suspect. So I'll give you a description of somebody, you get you should suspect. Okay, so, yeah, it might likely be this, but you should also be suspecting this. What's the worst case scenario? What's the worst thing this could be? If somebody, Yeah, brain bleed, an epidural brain bleed. If you manage to actually rupture one of the great vessels in your brain that's usually way out towards the edge, you start out with concussion type symptoms, you get knocked out, you start to come back to, things keep on getting better until things start to get worse again. And eventually you build up so much blood in your brain, blood in your skull, that it starts pushing your brain out of your skull. And as you might imagine, that's a very bad condition to have. That's what's on our mind with this one. So yeah, concussions are bad, but these epidural bleeds, they're worse. And that's what we're going to be thinking about as we come on into that scene. So that'd be very typical for either an EMT or a medic to say, you know what, you really have to go to the hospital. No, I just want to sit on the sidelines and I'll get better, It's like, no, I think we should really get you to the hospital. And that's our mindset, and that's why we're making that kind of a suggestion. And then the major joint injury. So I think probably one of the greatest examples of a video that just makes you cringe is good old Joe Theismann. So I think most people have probably seen that one at some time or another, just because it's such a spectacular break that you see on that one. So this patient, I'm willing to bet that hurts really bad. I'm willing to bet that felt really bad. Pressure, ice, yeah, that's going to help some. Might you need something a little bit stronger past that. So one thing that the advanced life support unit can then provide is going to be pharmaceutical pain management. So just for an example as to how much we carry, we have a lot on us. So at any given moment on my belt, I'll have 500 milligrams of fentanyl, 2 milligrams of Dilaudid, 500 milligrams of ketamine, which if you're not familiar with ketamine, you're a derivative. So it's a derivative opiate, it just doesn't affect your breathing like other things do. And typically on a patient, I'll max out at 25 milligrams for a single dose. I got 500 milligrams on me. We have enough medication to medicate a horse. And so we can kind of get some of that process going. That's a great time to have us there to assist with that. And I think this person should probably go into the hospital and get checked out, especially if there's no circulation going to the extremity afterwards. So there's all dusky gray, no pulse in it. How quickly does that need to get managed? Time to go, right? It's right to life and limb. That's going to be something that you really want to have us involved on. And then this particular one, cardiac arrest on the field. Does it happen that you have somebody playing sports, really good shape, and then ends up in cardiac arrest? Unfortunately, yes. We do see that periodically, whether it's due to more congenital defects or if it's due to an actual traumatic event that happened during that. So let's get into a couple of case studies then. What would you expect EMS to do in a couple of situations that I present to you? So in this one, now you have players out there, one ends up injuring their ankle, just steps in it wrong, catches their foot on the ground, twists it around. What's the initial response going to look like? Who's going to be the first one to actually manage the patient?
Athletic trainer, or sport chiro, or sideline medic.
Somebody that's probably right there right now, right? So if you're going to be working on the sidelines in any capacity, is this something that you want to be able to manage? So you want to be able to split it up, things that you can do for them right off the bat, pressure, ace bandages. I think most of us find that ace bandages is one of our best friends that we ever use out there, just good to keep some pressure on it, keep it from swelling up. Ice, is there anything in the world that you can't fix with a cold pack? Maybe there's one thing out there that most things is particularly good for. So let's say that it is a ankle injury. By the time that the ambulance arrives, they're off on the sideline, everything's properly wrapped, splints applied, cold packs on it. What's the ambulance going to contribute in this case? Mostly transport. So that is an important function of an ambulance. We are mobile. We can move people around, and that's the main thing that you contribute. Now let's say that that right off the bat they're saying I'm not taking an ambulance ride. I absolutely will not take an ambulance ride. Can we make them go? So we'll be there to offer that service to the patient, and it ends up being their decision. And that's kind of the interaction that you expect on this one. Now, going on to maybe something that's a slight bit more complicated. A head injury. So sorry, I'll stop like that. So let's say that you have somebody that's got their head hit, you got some, superficial bleeding going on, no loss of consciousness. What's going to happen with this player?
You're gonna triage them, you're gonna rule out complications and determine whether it needs to be transferred or not.
Mhm. So a big difference here between the ankle injury, but if we show up on that one, my mindset is nobody's ever died from a sprained ankle. There's no underlying tissue that's underneath that. I mean, could you end up with some problems farther on down the road? Yeah, you could. But not anything that's going to really meet the mindset that I'm going to have at that. Now, when we start talking about the head, though, what's underneath all this superficial tissue? So a rather important organ, like the number one organ that the entire rest of your body supports. So guess which one I'm going to really start to advocate? You know what, sir, that's a pretty good hit to your head. Oftentimes I tell people that my x-ray vision doesn't get installed till next week. I can't tell you what's going on underneath. You very well may have some underlying damage. I would really suggest that you go to the hospital with us. I think we should go to somebody that can actually see inside things and start ruling out some of these really worse things that I'm suspecting. So it'll be a little bit of a different conversation I'd have with between case 1 and case 2. Case 1, to be quite honest, I'm probably not going to push that hard. I'm going to offer it, but in terms of saying that, really bad things could happen if you don't come with us. I'm probably not saying that in case 1, but case 2, absolutely, I'm going to start laying it out. Worst case scenario, you have bleeding inside of your brain, you might end up dying if that goes unchecked. That's going to be part of the conversation I have with them, and it's actually my responsibility to have that conversation with them. So I get in trouble for not informing them of the risks of not seeking treatment. So that's a little bit of a difference that we see here. Sometimes people think that we're overreacting on this. That one's been put out there before. But once again, you just have to understand the mindset that we're coming from in these cases. Maybe it's bad, maybe it's not. The thing is, we don't know, so we'll always go on the side of caution. Now let's go with shortness of breath. So especially with kids, so about 50% of kids that have asthma no longer have asthma-type symptoms by the time they become adults. So oftentimes with the younger players, we have a slightly higher risk of having reactions with that. But otherwise, whether it's going to be allergic reactions, other kind of factors coming in, people that have acid reflux have an increased risk of having lung issues. Whatever it is, they end up having some unresolved shortness of breath while they're out there playing this sport. Now, I am pretty darn sure that there's not a feeling in this world that's worse than not being able to breathe. If you find yourself unable to actually breathe, I'm pretty sure that there's no other feeling that I would rather not have. So when we arrive on these patients, once again, we're working it. Air goes in and out, blood goes around and around. I'm seeing a massive problem with air going in and out right now. So this is something that we're going to start to get very aggressive with, and we're going to get aggressive with it right now. So let's say that they're starting to lock up. They're breathing at about 50 times per minute, short, little gaspy breaths. What should we be doing at this point? Forcing them to breathe. Now, whatever that ends up being, so take for example asthma. Asthma is a problem with not being able to get air back out. So you end up with air entrapment inside the chest. What's it mean to force them to breathe? Move the air back out of their chest. Pushing down the chest while forcing air out, you actually get kind of a weird whistle sound from inside the throat. If you can imagine somebody with their mouth hanging wide open and they whistle. It's a very unique sound that you get with that kind of condition. But that's going to be the things that we get on top of right away. So as we run our students through scenarios and whatnot, that's one of the things that we want to see. We want to see it now, which should have started 5 minutes ago. So the second that you get that stuff going, the better they're going to do. So we're going to start running down that, and after we have that initial care in place, that's when we're going to turn around and start asking other questions. So as we kind of look at our scenes, a lot of times when somebody shows up, they want to say, what happened. It's a very natural thing for somebody to show up to emergency and say, what happened? We break all of our people of that habit, and we just simply ask, is air going in and out? Is blood going around and around? Take care of that stuff. Once when that stuff's taken care of, now you can start figuring out what happened. It's a matter of prioritization. So nothing takes priority over that air going in and out, blood going around and around. So in this kind of a case, do you have very clear usage of the ambulance? So they're probably the top people for managing this patient at this time. This is our bread and butter, this is what we do. So we want to get right on top of that. And in this particular case, so I'm going to pick on hockey again. For some reason, it seems like hockey always has some pretty fantastic injuries going on with it. So in this particular case, what these pictures are showing, you kind of see it in the little black triangles. I don't think it shows up very well on the projector. But we had a slap shot towards the goal. The player got hit right on the top of the sternum by the hockey puck. So it gets hit. He doesn't think too terribly much of it. He starts to skate towards the side, gets very, very dizzy, falls down on the ice. He's in full cardiac arrest. What happened?
Hit at the right point in the cycle and stop the heart.
So one of the things about the heart, of course, is that it's electrical, and if you hit somebody right on the top of the sternum, it puts a little bit of electricity down into the heart, just right around 10 to 12 joules down into the heart. If you interrupt the heart at just the right point in its cycle, guess what your new rhythm is? So we call them defibrillators for a reason. Ventricular fibrillation. So think about just short-circuiting your heart, where everything now just doesn't work the way it should. There's no organization, and literally sits there and quivers inside the chest. If you were to crack open the chest right then, you would see the heart shaking and vibrating with no effective pumping action. So you can continue to live for about 10 seconds in that state. So they get hit in the chest. It's not like they drop down dead right now. They get hit in the chest, and they kind of think about it for a second, and they'll move around a little bit, start to get sluggish, and now they go down. It's about a 10-second window during which this happens. So who do you want present as soon as possible? Yep, so we want to get CPR in place. When we talk about doing CPR, there's the old AHA method, where you would go, hey, you okay, open the airway, try giving a breath, doesn't go in, readjust, give another breath. All that stuff is going out the window, by the way. If somebody looks like they're dead right now, what do you do? Push hard, push fast. Go right to compressions right off the bat. So we want to see that happen as soon as possible. And in this case, who do you want on scene as soon as you can possibly get them on scene? ALS. So cardiac arrest, you want ALS on scene. That's how you're going to get the best chance of survival. The survival for this is roughly 25%. So about 3 out of 4 cases of commotio cordis, which is what that condition is called, when a traumatic hit to the chest causes you to arrest, only has about a 25% survival rate. So the quicker you can get that care in place, the better the patient's going to do. So we'll kick it on up to questions. So I think we're just about out of time. I want to make sure to answer any questions that you have.
I'll have a question for you, Tim. So when we're on a scene, maybe we're not used to doing this event. Maybe the doctor going to do a MMA event, for example. When I was in North Dakota, I was a commissioner. I did a lot of MMA, and we had to have paramedics that were part of the contract. So what type of communication should we have with the EMS team, understanding maybe their level of EMS? Are they EMT? Are they paramedic? Therefore, are they BLS or ALS maybe? And do they have life-saving medications available, things like that?
Yeah, it'd be great to know the capabilities. At the same time, too, just kind of understand that the other people that are there is much of a mystery to us as we are to you. So oftentimes, we're just kind of wondering at what point do you really want us to intervene? So say that if we're at a rodeo, you got some other people that are taking care of some of the event. We want to know, it's like, okay, so at what point do you want us to get out in the field? At what point do you want us to hang back? Will you bring them to us? Should we get out there and go get them ourselves? So just to kind of have a little bit of communication so that it's a mutual understanding as to where that team's at. Because there is a little bit of variation as to how they get covered. And even in the same sport, say for example, high school football. During the regular season, you have to have an EMT on scene. It's required by the Minnesota State High School.
Public schools, yes.
Only for playoff games. Becomes a requirement for playoff games, and say that if you have an ambulance that's dedicated to the event and they transport somebody off scene, guess what you have to do with the playoff game? Stop it until they're back. You have to be present at all phases of the game. So that's just true for playoff games, not the regular season. Sometimes just kind of having that expectation laid out. You know, this is kind of our plan, pre-planned. We know that sometimes things get a little off the rails and there's something that you haven't accounted for in our plan. But the better that you can have that mutual understanding as to everyone's roles, capabilities, the better the event's going to go.
I've communicated with paramedics that if I give a signal to keep an eye on me if I'm going out there, and if I look kind of in your direction, give a signal of cross my arms, for example, get the heck out there.
Yep.
Great.
Any other questions?
Who's all EMTs in here? Just so that those of you that aren't can lean on fellow students or other providers in here to ask them questions. Because Tim Howie's not always in the hallway. He's a great person to lean on for questions like this, but you can also lean on some of your classmates too.
I'll vouch for them. They all did a very good job.
It's a great class. If you're going to be here yet for another year or two, consider taking it for sure.
Thank you.
Thanks, Tim.
Thanks for having me.
You're going to sign the sign-in slip that's going around. There's a couple of them going around. Grab them, throw it on your way out. And we'll see you next month. Next month we have Ray Rasmussen, who is going to be here from Augsburg. He's the strength coach for Augsburg. And he's going to talk to us about the strength coach's role. The strength coach's role on a sports medicine team. And then in December, I think we've got a little taste of Down Under. One of my friends from Australia, Brett Giroux, is hopefully still going to be doing December. So we'll see you next month. Thank you.